That's fine. Yeah, just type up, see if I wait for a couple people to get on there. Some people are saying they're there. Yeah. Okay, so we got some people on here. Awesome. Good morning. Good morning. Sorry for the delay in getting on here this morning, but this, like I was telling Alex who's here, this past week pretty busy. I coach a high school track team, and we had all of our last championship stuff this week, plus my son and my nephew who lives with me are both graduating high schools. We had all sorts of end of the year stuff. They had their prom last night. It's just like really, really busy, and I just couldn't get down here over this weekend to prep today. So got down here early today to get things ready. Now, what we're going to try, and I do this periodically. If we were here in person, I'd be doing a similar thing, in that we're going to, I've prepped the thoracic cavity, and we are going to try to open up the thoracic cavity live, and we're going to see how it goes. All right. I've done this a bunch of times. It should be okay. I just don't know how the pacing is going to be. So there might be a couple times where I'm like, listen, I'm not going to narrate too much, but you guys can just watch, where I might have like 5-10 minutes here or there where I'm going to have to pause and get some things ready. But I'm going to keep the camera on it. You'll be able to see what's going on. You can definitely ask in the chat if you have questions, and Alex will relay that stuff to me, and I can talk while I'm doing it. It's just I might not be giving you a lot of relevant information while I'm doing it, because I kind of have to concentrate a little bit. So let's see how it goes. Hopefully it's interesting. Hopefully the camera angles work. We'll see. Maybe it's terrible. Hopefully not. We're going to do our best, see how it goes. All right. So let me get the camera in place here. And the other thing is, it's only about 97 degrees in this lab today for some reason. The heat is on, so we're going to both try not to pass out while we're doing this, because it is ridiculously hot. Why sometimes does it get so yellow? Can you, you know what? Yeah. Can you click on the white balance, just let it take it off of the lock, and then put it back on? Okay. There, that got rid of it, right? Yeah, that's better now. Yeah, it's not so orangey. Yeah, if that ever happens, I don't know why. Sometimes it just goes to that, but yeah, it looks better when it's like this. Okay, and everything else is good. Perfect. Okay, so right now we're standing again on the right-hand side of the male cadaver. So he's face up. We're looking in on the right here. I'm standing on the right side. So the head and the face are up here, right? So this is superior. That's inferior. You can see the shoulder here, right? So this is medial. This is lateral. Now, I just had the face covered up to keep the muscles from drying out. So you can see that we got the toweling down here. So a lot of times I'm only going to uncover the spot that we're working on, because all this stuff, see, the muscles look really good now, but you'll see even by the end of the class, the edge of these muscles are going to start getting darker, because they're going to start getting dry. So we just try to minimize that as much as we can and keep things covered up that we're not actively working on, okay? So last time we finished up the face and the anterior neck, and we did all the muscles, right? We stopped there, and we did the glands and everything too, right? Okay, so we left off on that. Perfect. So we finished all that. Now we're moving down here. So we're going to start with muscles, because we're going to get to that first. Then we'll do a little bit of osteology, and then probably some more muscles. Then we're going to actually open up the thoracic cavity. So again, I have it prepped, but there's still a fair bit more that we need to do to actually get the thoracic cavity open. And hopefully we're going to see some cool things and be able to talk about some cool things. All right, so let's start with the thoracic muscle. So the first one we want to identify is pectoralis major. Pectoralis major. And I'm just going to outline this guy for you right here. This big muscle here that I'm outlining, that's pectoralis major. If you guys can see right here, you see where, like normally this would be like right up against there, like that. This is actually two different muscles. So you see this like fatty line going down right here. That's where pectoralis major stops right there. And then this is your deltoid muscle over here. So they're pretty well like stuck together, but I did peel them apart a little bit here. All right, you can see they're still stuck together there. So that's pectoralis major. Now, all we want to do for pectoralis major is identify it. Don't worry about its function yet. Just identify pec major, that's it. Know this muscle, and then we're going to be able to reflect it out of the way. The reason we're not going to do function on this one yet is because it moves around the upper extremity, and we're not going to do the upper extremity until after the midterm practical. So once we get done with the midterm, we come back. This will be one of the first muscles we look at when we start doing upper extremity. All right, so we're going to take this, move it out of the way. It's just like latissimus dorsi on the other side. We didn't go over function, we just wanted to identify it. So we're going to reflect pectoralis major like that. And then the next muscle we hit, and where did I put my instruments? Hold on a second. Oh, so now this is laying. Oh, you moved it over a bit. So that's good. No, we definitely won't trip over it because I am going to be moving back and forth, so it's probably good today. Awesome. Okay, so after you move pectoralis major out of the way, the next one we get to is pectoralis minor, and that's this muscle that I'm moving right here. That's pectoralis minor. Now this one we are going to go over function for. So what you want to see is if I lift this up, hopefully you guys can see that there's like 1, 2, 3 little projections coming off this muscle, and that's going to match up where it attaches to this rib, and this rib. So this is going to be your second, your third, and your fourth rib. And we're going to see in a little bit how we're going to know that that's the second, the third, and the fourth. But just take my word for it for now that we're attaching down to that second, third, fourth rib. And it can attach to the first rib a little bit. It can also attach down a little farther, but this is probably pretty typical where it's going. Now, we can see the muscle fibers here going up in this direction, right? So I'm going to follow along this muscle. You can see that it goes underneath of further up underneath the pectoralis major up here. And we run into a bony process up here. So my finger is running into a bone, right? And that's going to be part of the scapula. And we're actually running into the coracoid process of the scapula. So let me grab the scapula here. And now I need different scapula. Hold on a second. Grab one of these guys. Here we go. All right. So I'll kind of show you how this works. So we're going to have the scapular. So this is a right-handed scapula. And here we're looking at the anterior side of the scapula. See, before when we had the body flipped over, we were looking at the posterior side of the scapula. How do we know? Because we could see this large ridge on the posterior side, and that was the spine of the scapula, which we've already identified, right? That's posterior. So we're going to flip it over, right? Like this. So this is how the scapula sits, kind of like this here, right? And I'm going to turn it a little bit. Here's that acromion process that we already identified. And then right next to it, or I should say anterior to it, is this process sticking out. That's the coracoid process. So if I kind of come up like this, you can see those two, right? This is posterior, that's anterior. So acromion, coracoid. So when we're up like this, the coracoid process kind of sticks out anteriorly, like that. So when I'm running my finger up here, and I'm pushing against that bony bit, I'm coming up and I'm hitting that process right there, which is that coracoid process. All right, so that's what pectoralis minor attaches to there. So we go from the ribs up to the coracoid process there for pec minor.
Chris asked where the pec minor is attached to the rib cage.
So right on the ribs, right where you're seeing it right here. So we'd have, you see this little part? That part there attaches right here. This part here attaches right there, right? And then this little part here attaches right onto the rib there. So you can see the ribs coming down like this, like here, here, and here. That's where it attaches. All right? And we're going to go over a little bit more of the ribs after we get the muscles out of the way so we can see more. So we'll talk about some of those bony spots a little bit. But it's basically just on the body of the rib or the shaft of the rib, the main part of it. Okay, so pectoralis minor. Again, we know that the scapula is the most movable thing we have. So when we have things going from the scapula to something else, the scapula is going to be the thing that moves. So when pectoralis minor contracts, pulls like this. All right, pulls like that, which is going to take the scapula, right? Take the scapula and move it down like this. Now, keep in mind that right now, because we've cut a lot of muscles and everything, his scapula is not where it would normally be. All right, so which meaning that the positioning of this is a little off. This muscle is a little bit more straight up and down if everything was where it was supposed to be. But as soon as we cut muscles, then things like move out of the way and they relax and they stretch and stuff. So just kind of keep that in mind. But pectoralis minor would pull down on the scapula, and it would take the scapula and move it like that, which would be depression of the scapula. So you want to think that pectoralis minor is synergistic to something like the inferior head of trapezius on the posterior side. Both of those things would pull down on the scapula. Just one does it on the anterior side, the other one does it on the posterior side, and they both pull down like that, right? So that's pectoralis minor. Let's get this guy out of the way. So we're going to reflect this as well, right? So once we get that out of the way, now we've exposed a little bit more of the rib cage so we can see the ribs coming over like this. You can see another one here. We're going to even uncover this a little bit more. We can see the clavicle right here. So grabbing the clavicle there, right? And along the midline here, and you can see that I've already made a cut right here. One cut. It's the only thing I've done so far ahead of time. Right along here, this is the breastplate. Right there. Right along the midline. All right? So, and we're going to go over some of that bony stuff. We got one more muscle to just hit here that we want to identify, and that is going to be serratus anterior. So this is one that we already mentioned. We did serratus anterior on the posterior side, and I related it to your rhomboids. Okay, rhomboids, both major and minor, they did retraction of the scapula. Serratus anterior was antagonistic to that. It does protraction of the scapula. So we identified it there, but I wanted you to see where it is on the anterior side as well. So see this muscle that I kind of peeled off here. So we're going to move this out of the way. See this guy that I'm moving? And you can see if I take this off, you can see a bit more of the rib cage, and you see how this kind of lays over the ribs like that. And if you look here, sorry, let's see if we can get it to stay. And hopefully you can see, if I kind of hold this up, that it's got these little finger-like projections. Right, so you can see like a little finger here, a finger there, a finger there. You can see another one right there. You can see this guy right here. And each one of those little finger-like projections, they attach to these ribs. Right, so we have an attachment here, 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 here. Right, so serratus anterior goes from the scapula out to the ribs. Right, and you can see those little finger-like projections. Now, this is why this muscle has the name serratus. All right, it's because of the appearance of the muscle. So if you look here, right, and if we kind of like follow kind of that jagged edge there, that it looks like the serrated edge of a knife. Okay, that's why it has that name, because of the appearance of those finger-like projections that touch the ribs. So again, this one, it's going to pull on the scapula this way, which is going to spread the scapulae apart, right? So if I grab the scapula and say the scapula is like on the back here, and I'm pulling it like this, it's going to bring the scapula like that. All right, so the scapula is sitting here. I pull on it this way, because right, we're scapula is behind the body. I'm going to pull on it like this. I grab it and I pull, and it's going to, the scapula is going to follow the rib cage and do that, which is protraction, right? So this way would be retraction going around the ribs, protraction. Like that. So it's following the rib cage. Protraction, retraction. And this one does protraction. Rhomboids and trapezius do retraction. All right. So we're going to let this kind of hang off like that. We got to get it out of the way. That way we can get to the rib cage a little bit better. Now, also note down here, if you guys can, let me move this out a little bit. See this muscle that I'm moving. Oh, let me see if I can hold that in place there. Let's grab this here. See this muscle that I'm moving right here? That is the upper portion of latissimus dorsi. So that's really wrapping around the back there. So again, we've already identified that one as well. I just want you to see where you can see it on the front, right? So that's latissimus dorsi. There was that serratus anterior. So we get those guys out of the way. like that, right? Now we've done all the same stuff on the other side so that we can really open up the thoracic cavity. Now, before we get to the osteology, we got a couple more muscles. Now, here's another one that we're just going to identify. Not going to worry about function at all. Just identify it, no function. And that's going to be this one here. So you see this muscle that I'm kind of moving here, right? That's coming from down this way, right? Down here. And this is going to be your external abdominal oblique. External abdominal oblique. We are going to see this one more when we get down to the abdominal cavity down here. But I just want you to note that right now we're just going to reflect this a little bit because it's going to uncover a little bit more of the rib cage. And also notice, hopefully you guys can you see those fingers there? Can you see that? I'll lay it on my hand like that. There you go, right? Notice that it's very similar to Serratus, and you see how they kind of interlace with each other. See that? All right? They make that little zigzag line there. So that's where if you ever looked at like say a bodybuilder who's very, very lean, anybody who's in shape and they contract their abdominal muscles, especially if they're doing like a lat spread and you're looking at it from the front, you'll see like a little zigzag line going on either side of their right below their chest muscles going over towards their abdominals, and that's going to be where serratus anterior and external abdominal oblique kind of come together like that. That's where they attach along the ribs here. All right, so we got external abdominal oblique. We're going to reflect that, and you see how you see a little bit more of the ribs here. And then we got this little bit here. See this bit of muscle there, and then you see those fibers are kind of going straight up and down. That's the very upper portion of your rectus abdominis muscle. This is your six-pack muscle. So again, another abdominal one that I just want you to know what we're moving out of the way. Don't worry about function. We're going to re-talk about this one. All right, so we're going to take rectus abdominis and just move that down out of the way. Now you see how you can see a bit more of the ribs here. Right, so we got that completely uncovered. And again, we did the same thing on the other side. All right, so we still have a couple more muscles because we got to talk about the muscles that are in between the ribs, the intercostals, right? But before we do that, let's do a little bit of the osteology here now that we got this fully uncovered. So again, we said that the clavicle was here. We said the breastplate is going down here, and then we have the ribs coming out like this. All right, so what you're going to do, and you guys can do this, and you should be able to palpate this. If not, it's not a big deal. But right now, take your finger and hook around the top of your breastplate. So push into the soft part of the bottom of your neck and bring your finger down. And you feel where you come down to a bone right in the middle, right? That, you're on top of the manubrium there. And if we go to either side, so if we pull down on that and we move laterally, right, then we're on top of the clavicle. So here I'm on the manubrium, I move over right here, now I'm on the clavicle. So right here is where the clavicle and the manubrium attach to each other, right? So this little bit, that little bit in the middle, feel how there's like a little notch there that you can settle your finger into. That's called the jugular notch. And again, that's the uppermost part of the manubrium. Okay, so we're going to start there. So if we start on that jugular notch and we're on the manubrium, I'm going to trace right down the midline like this, come straight down the middle. And what you can feel, now if you can't palpate this on yourself, you certainly can palpate it on somebody else, especially like say you had a patient, they're lying on the table, right? And you're going to feel that jugular notch, and then you're going to run your finger down like this. You're going to feel a bony ridge right here. There's a big, and it sticks out anteriorly. There's a bony ridge that sticks out, and that is called the sternal angle, right? The reason it's sometimes hard to palpate on yourself is when you're pushing in, like when you're pushing down like that, you're contracting your pectoral muscles, and then they can kind of blur that spot a little bit because the muscles contract and they stick out and then they cover that area, right? You can, if you can do it relaxed, if you kind of relax your chest and just kind of move your finger up and down, you should be able to feel that. Again, if you had a patient who is laying down, right, you can palpate. This is one of the easiest things to palpate. You start here with your fingers, you just run it down right there, sternal angle, all right? Now, that sternal angle, that's the name of the landmark, is going to represent the joint between the manubrium and the sternum. All right, so we got that breastplate there. Breastplate's got three components, and we said the top part is manubrium, middle part the sternum. That sternal angle is going to represent the joint between those two things, right? That's one thing it represents. The other thing, and this is why we want to be able to palpate this spot. You want to be able to find the sternal angle. Why? Because it acts as a landmark for us. And there's lots of things that we will say are landmarks. And it's just something that typically is easy to find and that shows us the location of something else, right? That's what landmarks do for us. So we can landmark this spot. We can feel it. We go, okay, we're on the sternal angle. I'm going to move laterally from that spot. Stay on the sternal angle, move to the side, right? And you're going to be right on top of the second rib, which means that this rib that I'm pushing against right here, second rib, every time, right? So you find the sternal angle, move laterally, second rib. And then you have a clinical landmark to know exactly what rib you're on. And then once you know where the second rib is, now we know where all the other ribs are because we can count up or down, right? So we can go up one, and underneath the clavicle, if I push down up in here, right, and it's kind of covered a little bit, that's the first rib. So that's the first, second, third, fourth, fifth, sixth, seventh rib. We can see down to the seventh. Now, the other ones are kind of trailing off over here, but we're going to go all the way down to 12 down there, right? But we can see the first 7 here. First one, you can't really see it, but we can palpate it. 1, 2, 3, 4, 5, 6, 7. All right? Those are the ones we can get to. And now that we know we can number the ribs, we can also number the intercostal spaces between the ribs. Right? So think of that word intercostal means between ribs. And so we go from rib 1 to rib 2, and the soft region in between is the first intercostal space. Second, third, fourth, fifth, sixth intercostal space. All right? And we can keep on going down. So now, by finding that sternal angle, you find the second rib, it allows you to number the ribs and number the intercostal spaces. Now we know if we want to listen to heart sounds, breath sounds, we want to put on an EKG, anything like that. We want to draw fluid out of like the lung cavity or something like that. All of those things need to occur in particular intercostal spaces. Now we have a concrete way of finding those things. All right, so if an EKG lead's got to go on the fourth intercostal space, you can palpate right here, go, there's the second, third, fourth right here. In that space is where we want to put an EKG lead, right? And there's other parameters too in terms of how far along here you would do it, but we'll worry about that stuff another time, all right? But at least you have a way to be able to find your bearings here. Okay, now, what else? So as we move down, we said we got the manubrium, we said we got the sternum, and we come all the way down, and if you can see right here, there's a bump sticking up right here, and that is going to be the xiphoid process. And that's the very bottom of the breastplate. So manubrium, sternum, xiphoid process. That makes up this whole thing here. All right, what did I cut through right here? I cut the manubrium in half. All right, so here's the bottom half of the manubrium. There's the top half of the manubrium, and I used a bone saw to cut the manubrium in half. And that was just to allow everything to separate a little bit, to give me a little bit more space, so that you'll see when we're opening up the thoracic cavity, it'll help us out a little bit. Okay. What else can we see here? Now, when we're talking about the ribs, and I'm going to move the camera over to the skeleton for a second, because I want to show you some stuff there, and then I'll relate some of that stuff back on with the body. So give me 1 second here. And just got to wheel the skeleton over and let me get rid of this and just check this. All right, let's get this over here. Boy, he's seen better days, so I got to fix him up a little bit. Oh, I knocked the cord. It'll come back on 1 second, guys. Sorry. All right. Yeah, I think it retains. It actually retains stuff now. So it's a little bit better, yeah. All right, can we see here? I think I'm going to move a little closer. I'm going to tilt this down just a touch. Let's see how that is. Is that good? We'll go right there. Good. All right, let's just stop him swaying. So you see we're missing an arm over here. I got to screw it back in. This guy's falling apart. If we look at the rib cage here in this whole area, I'm going to point to some of the stuff that we already saw on the body just so we can correspond it, right? So we got the clavicle here. There's that jugular notch right there. You see this line? That is the joint between the manubrium and the sternum. That's where we palpated the sternal angle. Again, come to the side. Notice that the second rib is right there. I don't know how well you guys can see the first rib up here, but you see how it kind of tucks underneath the clavicle here, right? So there's the first rib. Second rib in line with that sternal angle. Third, fourth, fifth, sixth, seventh rib. This is what we could see down to here. We were missing the stuff over here on the side, which we'll go over in a second. Now, notice that when we're attaching to the breastplate, right, we follow the ribs over, and you see how we have this kind of translucent part here. That's cartilage. All right, so this is bone, that's cartilage there. So your ribs all have a cartilage connection into the breastplate, all of them. And those are going to be your costal cartilages. Costal cartilages. On the bodies that we're looking at, in about, right, I'm 46, okay? And at the point that I'm at, I probably still have a fair bit of this cartilage, but as I get older, this is all going to ossify, all right? And that cartilage is going to be replaced with bone. It's going to become more brittle, which is why it's so much easier to, like, fracture your ribs when you're older, because they're not as pliable. When you're real young and like you guys, you still have plenty of cartilage here, which means the rib cage is really, really movable. But as you get older, this gets replaced with bone. All right. So the cadavers that we're seeing, this is pretty much all no cartilage left for the most part. It's all ossified. Not on everybody. Some people go through that process more than others, but a lot of the older cadavers we see is pretty much turned into bone for the most part. Okay. So. We got those spots. Now look at the junction between the cartilage and the bony part of the rib here. Right here, you see that line. And we can see it here. You can see it here, here. That's the costochondrial joint. Costochondrial joint. And you hear that word chondrial in there. Anytime you hear that, you're going to think cartilage. All right? Condyle, chondrial, condylar, all those word roots that have that same part in there all refer to cartilage. All right, so costo is going to be the bony part, chondrial, right, is going to be the cartilage part, and that's the joint between those two things. So hopefully we can demonstrate that as well. All right, now last thing is let's talk about types of ribs. We have 12 pairs of ribs, and within those 12 pairs we have 3 categories: true, false, floating. Floating is also false. So like the last category is both. It's false and floating, right? So we got true ribs, false ribs, and then false and floating ribs. That would be the third category, right? So how do we tell the difference? The first 7 ribs are going to be true. So we got 1, 2, 3, 4, 5, 6, 7 down to here. And the way that they're true, or the way you can tell, is that if we follow the bony part of the rib over, each one of those first 7 have their own individual connection via costal cartilages over to the breastplate. They all have their own connection, right? So true ribs have a direct connection to the breastplate via the costal cartilages. Now, I'm going to turn this just a little, okay, here. And look here. This is 8, 9, and 10, right? 8, 9, 10 there. These are your false ribs, okay? Why? Because if you follow the bony part over, they attach to these costal cartilages. Those cartilages join together here, and then they attach to the cartilage for rib 7. So they don't have a direct connection. They have an indirect connection. Cartilages here first attach to the cartilage for rib 7, then they attach to the sternum. So they have an indirect connection via their costal cartilages. That would be for 8, 9, and 10. Now we're going to turn a little bit more, and here we can see 11 and 12. Okay, these two here, 11 and 12. These are your false and floating ribs, all right? They're false because they don't have a direct connection, and they're floating because they don't have any connection, right? You can see the anterior ends of these ribs, no costal cartilage is associated with them at all. All right, so you got true ribs, false ribs, and then the last category, you can just say they're floating, but just know technically they're also false, right? They're false and floating. Okay, so that takes care of the osteology. And now I'm going to show you some of those same spots on the body so we can talk about where we're going to make our incisions and where we're going to cut to be able to open up the thoracic cavity. And then we're going to keep our fingers crossed that this is going to go smooth. We'll see. get that out of the way. And we'll also talk about why it potentially will not go smooth. We'll see. All right. Try to not knock the cord too much here. There we go. Get back over there. Flip, flip, flip. Come on. There we go. Okay. Let's come out a little. Actually, you know what? Never mind. I lied. I'm going to come down a little farther. Zoom in, then we'll zoom back out after.
Oh, Chris asked if ribs 11 and 12 are vestigial ribs.
No, they're just floating. They just don't attach on the front. That's all. But why? Not 100% sure. Probably for increased mobility. Like we'd be a little bit more bound up in our lumbar and thoracic regions if those two were connected in the front.
Yeah,
but
you actually asked that, like if it's probably because of flexibility.
It may be maybe ranges of motion, but again, when we get into that stuff, a lot of times we're guessing. You know, it's certainly outside of my expertise to be able to know. But even the people who claim to know are still basically giving you an educated guess. You know, for why. Yeah, but those are the ones, I guess clinically, and it is good that we talk about those for a second, that those are the ones you pay attention to more because any sort of injury to your rib cage, the ribs you're worried about the most are the 11th and 12th ribs. Because these other ribs, because they're along their whole length, they're kind of held in place, right, via the costal cartilages or via their attachment to the vertebrae in the back, that if you break or fracture one of these ribs, typically the muscles and everything around them hold everything in place, and it's okay. That's why you don't really do much besides rest, and they'll heal themselves up. But the 11th and 12th ones, because they're sticking out anteriorly and they have no anterior connection, that a strike to the front, right, can break the ends of those ribs, like fracture them. And right in those areas, you have a lot of sensitive things coming together. Like in here, we have the lungs coming down that way. Down here, we have the liver coming up this way, plus the kidneys, plus the spleen, depending on which side you're on. And those floating ribs are all kind of laying right over the junction between all that stuff. So if you get a fractured rib there, and just so you know, when you have a broken bone is like glass when it breaks. It's extremely sharp. So imagine inside your body, that's why like compound fractures are dangerous, because you moving around with a compound fracture is like you moving around with razor blades inside your body. It just will cut things, arteries, veins, nerves. It'll lacerate stuff, right? So it is pretty dangerous, very, very sharp. So those broken edges can cut things, and obviously you nick your liver or your spleen or your kidneys, and you will bleed a lot. And you know, so potential clinical problems in those areas from broken ribs. All right. So looking here, next thing we want to look at are those intercostal muscles. So we can see the bony parts of the ribs here, and we're going to look at the muscles just to give you an idea of some of those spots that we're looking at, right? So again, we got the breastplate here, we're coming out. So this area is where we're going to have those costal cartilages. Now, a lot of times there's a good color change between the cartilage part of the ribs and the bony part of the ribs, and we're not seeing it real well. I can see it in person. I don't know if it's coming up on camera, probably not great, but right about here is where we go from a lighter color to a little bit of a darker color. And hopefully maybe you guys can see the same thing here. See, like right about there, we're going from a little bit lighter to a little bit darker. And as this body sits a little bit, this will probably become a little bit more pronounced. But that would be that costochondrial joint. So about here, here, right? Right about here. It's going to be about here on this one, and down here on that one. And again, I understand that on the camera, maybe you don't see it real well. It's okay. But that's where it would be. So cartilage here, the bony part of the ribs here, costochondrial joint there, right? And again, we said this was second, third, fourth, fifth, sixth, seventh rib that we're looking at. All right, now let's get to the intercostal muscles. So think of the name intercostal, means between the ribs here, right? And we have a bunch of muscles that are going to be in between those ribs. And we have separate ones of these. So we have a whole full set of intercostal muscles between the second and third rib. Then we have another full set between the third and the fourth rib, and another full set between the fourth and the fifth, and so on, right? So they're going to have 3 layers here, and that's going to be stacked on top of each other from superficial to deep, right? So we're going to have 1, 2, three muscles all stacked on top of each other. And that's going to be your external intercostals, internal intercostals, and innermost intercostals. Those are going to be the layers, right? And again, they're all stacked. So we got external is the most superficial one. When you cut that one out of the way, you got internal intercostal. Cut that one out of the way, you have innermost intercostals. All right. Now, the other thing you want to note about these muscles is they are going in different directions. So if we're standing here, and again, this is superior, this is inferior, this is medial, this is lateral. External intercostals are going to be oriented this way. From top to bottom, they go medially, like that. Internal intercostals are going to be like this. From top to bottom, they go laterally. All right, so they make an X. Externals lay this way, internals lay that way, like this, right? Innermost intercostals go in the same direction as internals. All right, so externals like this, internals like that, and innermost also like that. So they're laying on each other like this. And we can see this here. So I cut a little bit here so we can see. So let's grab right here. And maybe I did, yeah, a little bit better on this side. See this muscle that I'm grabbing here? That's external, right? It's going this way, right? But if I move that out of the way, see these fibers here are going that way. And you see how they continue under external like that. So I cut a little bit of external so you can see. The edge of external intercostals is right here. We move that out of the way and you can see internals. And look at how the internals are going that way up here, and it just continues underneath. We can see the same thing here. Here's a break there, so this is all externals, and hopefully you can see a little bit of internals there. There's some fascia covering that up still. And here you can see the same thing. See, I'm going underneath of externals, and notice, look at the lead edge of that external. See, it's like that, and look at these lines here. You see how they're going that way, so they crisscross like that. This would be external, and then you can see internal going underneath of it like that. Okay, and you can see the same thing right here, externals, internals. All right. Okay, so that takes care of that. Now for the intercostal muscles, you're going to note that they are just assist you in breathing. And the intercostal muscles, there is a fair amount of debate over what the individual intercostal muscles do. Some people, like myself, argue that all of the intercostal muscles act to stack the ribs up. They all elevate the ribs. They shorten the distance between each one of the ribs, helps with elevation, and then when you stop contracting them, gravity pulls the ribs back down, in addition to potentially other muscles, which we'll talk about in a different time, to depress the ribs, right? So other people say that external intercostals are more involved with elevation, and internals, I think, are depression. I forget what the argument is there, but again, there's a lot of debate, not 100% sure. And it also seems to vary a little bit depending upon what type of breathing you're doing, that they can kind of work both ways, and it depends on how you pair them up and everything, so that there is some debate there, right? So we're just going to say that all of the intercostal muscles are related to breathing. Let's say that. I think everybody could, at least the two different factions will agree on that, all right? What else? So we can see externals and internals here. We won't see innermost until we take the breastplate off and we flip it over. That's when we'll do innermost. So if I ever ask you innermost intercostals, it'll be taking this, flip it over, and ask it to you from the inside. All right. Now we're ready to open this thing up, and let's see how it goes. So what we're going to do is I am going to cut off the intercostal muscles right here, okay, in between the first and the second rib. So we're going to get rid of all these muscles. I'm going to completely take them off the body. And we're also going to clear out as much as we can between the 6th and the 7th rib down here. All right, so we're going to get into these intercostal spaces. So I'm going to take those muscles down. I got to do it on both sides. I will, I'm going to elevate the camera a little bit so we can kind of see hopefully both sides, and I'm going to turn it. This will not be a view, excuse me, that I would normally show you, because it's going to be way more like bird's eye view, like right over the top, instead of point of view like I'm showing you now. But I'm going to do that so that I can work freely, and I'm going to kind of get this ready, and then we'll come back. So if you guys want to just watch this part, that's cool. If you want to take, 5-10 minutes to go do something and then check back in, you can do that too. All right. If you kind of just keep the sound on, I'm going to be talking about stuff, but I will say when it's time to come back when we're actually ready to go over stuff. So it's your choice, right? But it is going to be a little bit of a pause here. And then we'll see. I don't know how this is going to go, but hopefully it goes well. So we're going to kind of come up a little bit here. I'm going to move. I'm going to get this nice and high. Something like, maybe a little lower. Not like that. Let's see how that is. And then I should be able to work and not have to worry about this, right? So if I'm on either side, you can see the whole thing now? Okay, cool. All right, so let's see how this goes. And again, this part is not things that are going to be on the practical, meaning, you know, just I might be talking about stuff, but it's going to be more conceptual things, not anything that's going to be on the practical. So we're going to take pec major out of the way, pec minor out of the way, serratus anterior out of the way, external abdominal oblique out of the way, rectus abdominis out of the way. So all the same stuff I did on the other side. So we really open up that rib cage as much as we can. All right, so let's see if we can get in here, and let's get rid of some of these muscles here. All right. So we're going to lift up this external oblique, which I already got a little bit, and we're going to cut this guy off. So we're going in between external and internals, and I'm just cutting it off of the second rib. So we're getting under here. Cut this down. Can you see what I'm doing here?
Yeah.
Pretty much? Okay. So yeah, I'm not going to bother zooming in on any of this stuff, so just so you can kind of see bird's eye view of what's going on, and I'll talk about it a little bit. All right, so that is all external. Now we're going to cut it off up here. And again, we're completely removing this. I don't completely remove too many things on the body, but this area we really don't have a choice. We've got to, externals have to go. They're in the way. We got to get rid of them. Okay. Let's come down here. Like that. All right. So that's external on that side. Gone. Now we can see the fibers going the other way here, and this would all be internals. So I'm going to get underneath of that as well. We're going to get that out of the way. Come in here. And we're going to get under the internals.
Why don't you just go in through the bone saw?
Because we'll see in 1 second. Is that somebody asked that, or are you asking?
No, I just asked.
Yeah. Yeah. So Alex is wondering why are we just not going straight for the bone saw? You can, but you will destroy the covering around the lungs, which is the pleura. And we are going to destroy the pleura, but we're basically trying to destroy the pleura in a controlled manner, instead of just going through and obliterating it. You don't have to do it the way I'm doing it, but hopefully, if, fingers crossed, things go well, you're going to see some things that I would not be able to show you if we just did obliterate the pleura. So again, the pleura is the covering around the lungs, right? So we're trying to preserve that as much as we can so that I can give you a really, really beautiful picture when we open this up. So let's get rid of this. Okay. All right, so that's internal. Intercostal out of the way, and innermost. So I kind of took internal and innermost off in one shot. Now, right here, see where I'm pushing against? Right there. There's no more muscle in this area, and now I'm actually pushing against the lung. All right, and I'm going to show you a little bit more close-up of this later, but let me get the other sides, and then I'll adjust the camera and show you. But we're right up against the lung there, and that's really where we were trying to get to. Now, I'm going to find right here, coming right down this way, in between these ribs, are an artery and a vein that I need to locate and also cut, right? And these are going to be ones that you're going to hear about later, but these are your internal thoracic arteries and veins. So it's not anything you need to worry about right now. Don't even worry about it. I'm going to re-mention these, and they're just going to be, when I mention them, I'm going to go, remember that artery and vein that I had to cut when I opened up the thoracic cavity? That's these guys, right? So it's something that we will talk about later, but it's basically right here is where they are, and we're just going to snip these guys. Perfect. Those guys out of the way. Actually, there's the other one. So that was the vein I just cut. Here's the artery. Good, that's done. All right, so now we're clean. This is all clean cut through there. Done with that. Now, we're going to do the same thing down here between the 6th and the 7th rib, and this is not going to come apart as nicely as that did up there. So I'm just going to hit this real fast, cut off some of this stuff, and I'm basically doing the same exact thing. I'm going to get underneath of external intercostal, and I'm going to cut it off the ribs down here. We're just going to bring this back a little bit. And actually some of the internals are just coming off with it. It's a lot of times a little bit more messy down here. It depends on the person too. Sometimes these muscles will separate very nicely. Many more times it's kind of like what we're seeing now where they don't want to separate super nice. But we're going to chop off some of this stuff here. Let me get in here with the scissors a little bit. You can see as I'm opening this up, you can probably see those ribs moving a little bit, right? And I'm just going to try to really get in here and cut these muscles off. And again, I'm just kind of cutting everything here. Externals, internals, innermost. I'm not really making much distinction between them here, just getting rid of them. We already popped through the pleura a little bit, unfortunately, but that's okay. This area is tough to keep the pleura intact. You can see, like, right, see?
I didn't know it was like that close.
Oh, yeah. Yeah, the outer covering of your lungs is adhered directly to the underside of your rib cage. All right, so there is no space there. The outside covering of your lungs is stuck to your ribs. It's very, very easy to puncture somebody's lungs. Anything that goes in between the ribs here, obviously a scalpel or even just like a pin could do it, right? If you just pop right between there and go in through this muscle, there's no bone or anything, just pop through the muscle and get through that outer covering of the lungs, you could potentially collapse somebody's lung doing that. Very easy to collapse your lungs. I'm just cleaning some of this off a little bit. Okay, so that takes care of that area. We'll clean that a little bit better later if we need to. All right, so let's do the same thing on the other side now. And go right here. Yeah, and I don't know where I will cut this off today. So if things are going poorly, I may end things a little earlier, and then we'll just pick it up next time after I have it all cleaned up. As long as we can keep up a good pace, I'm going to go for a bit here. All right, but again, it's always, the recordings are always going to be available later. So if you guys do have something to do and you end up having to bail, that's fine. You'll be able to jump right back to the spot. I would just note, if you guys do leave, just kind of note where we are, like get a timestamp. That way you know exactly where to start off from if when you pick back up on it later. So not a big deal. I'm hoping that this will be somewhat interesting to watch live, especially when we get into it. This is the boring part right now. We just got to get past this part, and then it's going to become a whole heck of a lot more interesting. Okay. That was external there. Now let's get internal and innermost. Get these guys out of here. My goodness, when I say it's hot in here, boy, it is hot inside this lab. This is what it used to be like before we moved into here, when we used to be in another building on Bush. This is it's gone. It's it was called Doolittle, and it's, I forget the building that it is. Like if you go on Hill Road, right, that connects like the golf course to over here, right? Right when you're on our side and you're turning up over Hill, it's that first building that's on the left. Not Nelson. Nelson would be on the right. It's the newer building that's on the left. That used to be. We were in an emergency constructed, basically like a FEMA trailer, right? And it was temporary construction that they did way back in. I want to say Doolittle got built back then in maybe the late 70s, just as temporary, and they kept that thing. That temporary construction that they never did maintenance on. We stayed in there until 2007 or something like that. Like it was basically the ceilings were falling down. Like in the wintertime, if it snowed outside, it snowed inside the lab because there were holes in the roof, right? And when it rained inside, and there was no air conditioning and no heat. So in the wintertime, kids would wear their hats and their gloves because it would be 40 degrees inside the lab, like or less. I had to cancel class sometimes because it was too cold. That's like, and in the summertime, easily 90 to 100 inside the lab. Like it was the worst. It was the worst. We're so lucky that we're here now. It's not fun. That's Rutgers for you, though, unfortunately. In some respects, Rutgers is great in some areas, and not. They are bad. Yes, I'm going to say bad, but bad. That's every university, every single one across the boards, pretty much is lacking in keeping up on maintenance and stuff like that. They just don't like to spend money on that stuff. All right, so we're going down to that 6th intercostal space. So I'm going to clear out those same exact things here, right? 2, 3, 4, 5, 6, yeah. Yep. Make sure I'm in. Double check my count and make sure I'm in the right spot, right? We don't want to be cutting the wrong intercostal space. Not that it's not the end of the world, but try to keep it the same on both sides here. All right, and again, these muscles are just a little bit more kind of falling apart for whatever reason. Right through it. Damn. Right. This area is just always terrible down here. Never comes out good. Well. All right, we're getting there. We're doing pretty good. This is coming out not too bad. Actually, it's not the end of the world that I cut through this pleura a little bit because it's actually going to give us a decent picture here. Good. All right. I think we're good. So now let's switch side. Yeah, I think I'm going to show you over here so you can see it a little bit better. So let's bring this around. Swing the camera around here. All right. So I'm going to come up nice and close right here. This is a good representation. Like that. All right, so what the heck are we looking at here? So we're zooming in real close in between that 6th and 7th rib, right? So we got all those, sorry, I'm trying not to autofocus. So you can see those intercostal muscles here. You can see them again here. They're all gone. You can see where I cut them off. Now you see what I'm pushing against. See this membrane? See how that's kind of pliable there, right? That's the outer covering of your lung cavity. And what we're looking at here is parietal pleura. Okay, so let's start with all of your organ systems are covered with membranes, okay, everywhere in your body. And this is just fascia. Remember when we talked about fascia encapsulates everything, right? So it surrounds your muscles, it surrounds your bones, it surrounds your organ systems, it surrounds your body cavities, right? We're going to have fascia around everything. Now, sometimes we're going to give the fascia a special name depending upon what region of your body it's surrounding, All right, so the first type of fascia we're going to see here is pleura. Pleura is the fascia that covers and surrounds the lung cavity. All right. In your abdomen, that same stuff would be called peritoneum. Right? Around your heart, it's called pericardium. Around your central nervous system, it's meninges, or your meningeal layers, right? All that stuff is special names that we give to fascia surrounding those areas. And some of that fascia is specialized, has special functions and everything, but in the end, it's fascia. It's just a membrane covering an area, right? So here we're looking at into the lung cavity. So when we have the pleura here, we have two types of pleura. You're going to have parietal pleura, visceral pleura. Now that's going to be the same no matter what body cavity we're in. So meaning in the abdomen where we have peritoneum, we have parietal and visceral peritoneum. Around the heart, we got parietal and visceral pericardium, right? So we're always going to have these parietal and visceral layers around our organ systems. Parietal is more superficial. Visceral is deeper. Okay? So let me grab my probe here. And let's just look. See how I cut through on accident? I didn't mean to cut this. It's just very hard to keep it all intact. But here's that parietal pleura, and we can see we can get under it. See, it's intact. Right? And let me move some of that fatty tissue off there. Right? You see how transparent that is? See that? Very thin, transparent film. That is parietal pleura. Here, where the probe is, see down there? See how I'm pushing against there, right? Versus up here. Down there, I'm pushing against visceral pleura. And actually, the visceral pleura is attached to the actual surface of the lungs. So I'm pushing against the lungs right there. Here's that parietal pleura. You see that space in between here, right? That's because this lung right now, because of us opening this up, this lung is collapsed. Normally, in you guys and in somebody who's alive without a collapsed lung, there is no space in between the underside of the parietal layer and the top of the visceral layer down there. No space. That is, those two things are right up against each other, right? That would be normal. Collapsed lung means there's space in between those layers. So we're looking at a collapsed lung. But before we opened up his thoracic cavity, before I started doing any of this stuff, his lungs were still expanded. They were not collapsed. They only became collapsed once we punctured the parietal pleura and let air in there. And that air allowed those two layers to separate. Okay? So normally, question?
Yeah, sorry. Before you go into that, there's a question on the intercostal muscles.
Mm-hmm.
So, do the intercostal muscles have an antagonistic relationship with the serratus posterior and inferior?
Yes. Good question, and yes. Yes. The question is, do the intercostal muscles have an antagonistic relationship with serratus posterior inferior? Yes. In the camp that I fall in, where I say the intercostal muscles all do elevation of the ribs, yes, then they would do that. Other people would say that some of the intercostal muscles have an antagonistic relationship. Some of them have a synergistic relationship. Depends on what you believe the intercostal muscles do. And again, you can look it up. There's a fair amount of discussion about that. Okay, but yeah, the way you're thinking of it, and the way we talked about it, yes, the answer to that is yes. Okay, so what you want to see is that, see if I push on the parietal pleura. See, I'm pushing on it. You see how the ribs are moving a little bit? You can see I'm moving that a little bit. That's because the parietal pleura is stuck to the underside of the rib cage like tape. Okay, so we're going to try to peel this off. But you got to be careful, because if I push too hard here where I'm trying to peel this off, I will rip it like that, because it's delicate, right? So think about like a price tag on something. Sometimes you can peel off a price tag and it comes off nice and clean and neat. That's what we're hoping for. Sometimes you try to peel off a price tag and it leaves behind all that sticky residue and parts of the price tag stay on there, right? That's what happens a lot of times. We try to peel this off of the underside of the ribs and it breaks apart because it's stuck too much to the underside of the ribs. All right, so just so you can aware of that, right? Now, in between the parietal and visceral layers, so in between the parietal layer here and that visceral layer down there, they're not physically attached. It's fluid adhesion, surface tension that holds those two things together, which is why if something gets in there, like in this case air, we let some air in there, that it breaks that surface adhesion. Sorry, I keep on, let's zoom back out a little bit so it's not doing that autofocus. Oh, sorry, I knocked the cord. Come back on 1 second. There we go. Right? So, there we go. All right. Thanks. So they would be stuck together with surface tension, right? But if too much stuff gets in between the layers here, go ahead and click it off and on again one more time, and it should fix it. There we go. I can't have my gloves on there, so it messes up the color. There we go. All right. So if too much stuff gets in between the layers, the surface tension, say you get air in here or blood or fluid, and the parietal and visceral layers start to come apart, if they get too far apart, the surface tension is broken and the layers will separate. That's a collapsed lung, right? Now, you're going to note that down in there, the visceral layer was stuck like tape to the outside of the lungs. So parietal layer is physically adhered to the underside of the ribs. Visceral layer is physically adhered to the lungs. And those two layers are stuck to each other via surface tension. All right? So hopefully that makes sense. Let's just move up a little bit here. And here you can see where I was able to get this off and it's intact. So I'm pushing against the lung, and the lung is more collapsed down further, but up here it is still collapsed, but pretty much the lung is still right up against it. But you see that? Look at that. See? See I pushed against that? See that little air bubble in there? Is that showing up? Right? That means that's from down here. Air got in here, went in between the parietal and visceral layers, up, and a little air bubble, see, made it up there. That would never be there if these lungs were not collapsed, right? There would be no air in there, no space. But you can see that there is a little bit, so it is a collapsed lung, even though it's still kind of up against there. So hopefully you guys can see that. And that bubble that I'm moving there is in between the parietal and visceral layers. I'm pushing on the parietal layer, and it's sitting on top of the visceral layer. So this is the kind of stuff I can't recreate later, which is why it's kind of cool sometimes to see this come apart, because you can't put together these relationships once we separate everything, and you'll see why, because it just kind of destroys all of it. All right, so let's zoom out a little bit more here, and let's go back. Now I'm going to pause again, and we're going to try to cut this the rest of the way and just get the breastplate off. So what I'm going to do now, and this is where it's going to take a couple minutes, all right, depending on how well this goes. Come on, let's get us a nice view here we can see. There we go. Okay, so what I'm going to try to do is get here, and I'm going to try to push the parietal pleura off. I'm going to get up on this side, and I'm going to try to peel it off, and I'm going to try to get my fingers underneath the ribs, pushing that parietal pleura and unsticking it from the underside of the rib cage. I'm going to try to do that on both sides. Then we're going to grab out the bone saw, and we're just going to zip the ribs. Here, 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 right? We already cut this. We're going to do the same thing on the other side. We're going to lift this up like that, try to get everything unattached as best we can, and then we're going to cut the xiphoid process off. So we're going to cut right through the bottom of the sternum, like right about here, cut off the xiphoid process, and then we'll be able to take the breastplate off, and then we're going to take a look inside the thoracic cavity. So, all right, it's only 10 o'clock. We're good. I plan on fully going for another hour. So we started at 9. I'll at least go to 11, and at 11 o'clock we're going to make a decision on, can I finish up the thing I'm currently on? Can we move on to something new? We'll decide then, but definitely another hour. So you guys got another 5-10 minutes where I'm going to be talking, but it's not anything that we really need to see. And even that little interlude we just did is not anything I'm going to ask you on the practical yet. It's just to explain some spatial relationships that are about to get destroyed. So let's see what we can do here. All right. And I think, this might help for you to throw on a pair of gloves. All right, so Alex is actually going to throw on a pair of gloves and help. So if you do, we're going to kind of keep our eye over on the chat. So if somebody posts up something, we'll try to say it. All right, but for a minute, I'm probably going to need his help a little bit. So again, I'm trying to get my fingers underneath here. And why don't you double up?
Yeah.
Again, so it's just a slow process of me working my fingers underneath here, trying to separate as much as we can. do this little by little. So if I can clear down to the next rib, then we'll grab out the bone saw and boom. Now I'm gonna apologize to you guys ahead of time. It's fine. We'll just leave it. There's gonna be, it might get a little loud, so you might want to turn your volume down just a little, because when I use the bone saw, and I'll tell you when I'm gonna turn it on, it's gonna be just a little loud, but I won't need to keep it on for very long. I just have to, as I'm going through, we're gonna kind of be zipping these ribs down a little bit.
Do you want me to mute it when you do it? Or?
No, that's what I'm saying. Don't worry. I'll just warn them. Warn you guys it's going to be a little loud here and there. We'll let you know when that's coming up. Let's just see if we can. It's really when the pleura crosses the edge of a rib.
Yeah.
You know, so when we're coming in right at the top edge of each rib is where it's really stuck. Yeah. In between, it's fine. But it's when you get up, and if you can just break the seal a little bit, sometimes you're good, but it's hard. So it's nice to use, like right now, if you guys can see, I'm using like a blunt edge pair of scissors. This type of scissors is the one I use the most when I dissect. I know a lot of people use sharp edge scissors. I don't like that at all. I don't, but I'm in the minority there. But I like the blunt edge ones because I can do stuff like I'm doing here, and I don't need to worry about ripping something. It tends to push things out of the way, which is what we want. So we're trying to slide stuff out of the way here. So I'm being careful in the beginning because I'm trying to preserve this. If I get to the point of no return where it's like obvious that we've damaged it too much, then I'm just going to go much, much faster. But if we can do this, the payoff is really good if we can take our time here and get this done nicely. It's just difficult. Oh, and that's where I forgot to get these vessels. Let's hit these guys real quick. Those are those internal thoracic vessels I needed to get. Whoops, sorry, just bumped the camera with my head. All right, so that's down a little bit. Yeah, it's once I get started, I'm going to need you to start lifting this. So we create, not a ton, but enough to create a little space, because sometimes it'll just sit with a little tension. We can just get in here and do a little bit, but I can't get my fingers in here the way I need to and hold it up at the same time. It's a little tough. See, right here, I just popped it. Huh?
Use a probe all the way down?
No, we're going to start getting my hand underneath here. Yeah. That's why I'm going to cut. Now, I already popped a hole in here. I could feel it, but we might be able to salvage it. This is the problem. Once there's a hole, it's very hard to bring those edges back together again and not have it just completely go. Just need to get past. Okay, it's not bad. You can see my finger underneath in between things. So I'm trying to, again, I'm using my finger to try to peel that pleura out of the way. And so far, I think we're doing good. I think I got one little hole in the pleura, but I think, don't know, hard for me to tell. I'm not sure. I think we're okay. All right, let's see. So let's get the bone saw. All right, so give me a second here. Now, I'm going to tell you when I'll turn this bone saw on. And again, if you want to just hit mute on your guys' end real quick, that'd be fine, because it is going to be a little loud. But I'm going to zip this on both sides. All right, I'm turning it on. That's one. Now that we got that out, now we can cut the muscles along there a little bit. You know what I mean? Like, theoretically, we can get in between. We cut those intercostal muscles.
So you're going to do it one by one?
Yeah. So yeah, exactly. And then we'll start lifting this up. So we'll see how it goes. Same thing here. Hopefully. Like like that. You see how it's still got it. And then once we do another, then it's going to be easier. And like it gets easier as we go if we can keep it intact. But you see there? See?
Yeah, I see. It's already.
Yeah. So that's like, try to. All right. So this is what I want you to do. I want you to come like on the side and just do this.
Sure.
Like that. And I'm going to try to fix that edge. So we got an edge, a part where we punctured the pleura a little bit. And we're going to try to fix it. Okay. Hold on a second. Let me get my scissors in here. And this is the hard part here. Intact. It's not bad. All right, let's try this side. Switch me there, yeah. That's all right. Yeah, sorry. It's a little tough sometimes to keep an eye on where the camera is. All right, so what I want you to do is do it this way. I want you to get your finger all the way under, and you see how like when you push down like that, we want to actually like lift up and just curl your finger a little bit. Yeah, like that. Perfect. Perfect. Oh, see, this side's better. That's not bad at all. Actually, I thought I ripped this whole thing, and I did not. All right, so that side's going to be good. Let me get under here a little bit more. Yeah, that's clear. All right, so we can hit that second rib now. Cool. So that side's good. I got to hit that. Let's see. Are we down far enough on this side? No. Okay. Oh, yeah. No, never mind. We are. Beautiful. All right, so let's get the second one. All right, 1 second. Fingers. All right, bone saw is going back on. We're getting there. Once we get done with this part, boy, it's... All right, second one done. Now same thing. So, whoops. Oh, crap. Oh, boy. Sorry. Video just went out because I stepped on the cable and I lost it here. Always a pain in the butt to get in, right? There we go. All right. Should come back on. Sorry about that. It should be all right. Yeah, you don't have to. It's just me. I wasn't paying attention. Now we're good. It's good. Yep, it's good. All right, let's step over this time. All right, why don't you hook this and I'll get underneath here. Nope. Best you can. There you go. All right, let me see here.
Sounds like tape.
Right? So, yeah, see, Alex is saying it sounds like tape. I don't know if that's coming out on the audio for you guys, probably not. But I should be able to get it on audio a little bit later, but it does sound like we're peeling tape off, which essentially we are. All right, so that's through on this. That one's already cut. All right, let me get, here, we can let go of that for a second. Let's get the muscles here. Get these guys out of the way. That'll allow us to come up a little farther. Here we go. Oh boy, we're in for a treat on this guy. I think it's coming out really nicely, which hasn't happened in a couple semesters. So I'm kind of happy about this. And I know it's a little slow. Oh shit! Did I just rip it? Yep. I spoke too soon, maybe. It's all right. We're gonna have enough that it'll be fine. Let's get the same thing here. Let's work on this side. So I think you could probably do it like right here now. Just be a little careful on the edges. But the bone saw cuts it pretty clean, so it's not sharp. But it can be, so a little careful. Lead edge again, you know, where it wants to stick.
Right at the bone.
Right at the bone. Sorry guys, we're concentrating a little bit like on trying to be gentle here. Yes, right there. Very nice. Very, very nice. Okay. We're down to the next one. Back here. Farther. Trying to get greedy with how far I'm going to go over.
Yeah.
Okay, so that one is clear. All right, so we're at least down. Oh, that's coming off nice there. All right, so we're down past that next spot. We got one little, we're going to catch our gloves on that. Just make sure we haven't nicked our gloves yet. Not a big deal, but you know, kind of don't want body all over yourself if you can help it, I think. All right, so let's do the same thing here. So let's come like right here. I think you can kind of do it like that. So maybe one finger underneath both. Yeah, like that. Yeah. Let's just see if I can get this back down. And again, thanks everybody at home for being patient here. This is something definitely on the rewatch you can just fast forward through, but we're at like a crucial part here that I think this side might be too far gone. Yeah. Okay. So we're going to say no on this side. So the one side didn't work well, and that's okay. So that means we can go a little faster there. But the other side came. So this side is coming out beautifully. This side over here, not so much. And that's all right. That's all right. That means we can go a little faster on this side. So I'm just going to zip this the rest of the way because we're not going to be able to do it. And then we'll salvage what we can. Okay, we'll see if we can fix it up. So I'm going to cut through the rest of this and just get that side done. Okay. And then as we go, then we'll go this way a little bit. Yeah. You'll be able to lift up the whole thing, and then I should be able to get the rest of it pretty clean over there. This should be one of the best ones we've had, except for I just wish I didn't that hole right there. Yeah. That. But it's fine. The rest of it should be intact. Okay, so I'm going to turn on the bone saw again real fast. So we just went through everything else on that side. Because we ripped the pleura, I wasn't going to be so careful to try to keep it because it was already gone. So there was nothing to keep anymore. So now we're just going to cut through these muscles over here the rest of the way. Now this is all good. So let's see. There's a...
Yeah, And actually, that hole might have been
vessel.
a good thing because it introduced air, so that like. You know,
Well, if we can have no air is the best, because then it doesn't, see, it gets stretchy when you start to get air in there,
oh, that's true.
and then it doesn't work good. But this is not so bad. All right, can you hold that up there? Yeah, like that. And do you think you can put a finger underneath this one? Yeah. Okay, you see how it's just, yeah, forget it. Not going to come. Not going to come, but let's see if we can get it back right down in there. That's where we want to fix it up. It's so stuck there. Wait, it's like ripping the muscles off. Wow, that wasn't coming off there. I don't know if you can see. See right here?
Oh.
See how the muscles are like off, like that's how much it was stuck. So.
Right,
Yeah. That was not going to work there. Too stuck. Okay. Oh, nothing we can do there. So let's see here. All right. Yeah, the other side was not going to work, but we're going to try to get this down. Yeah, I got to lift up on that. This is good though. So we just gotta re-get it on this side. We got that one hole there, but that's not bad. And once we can, hold on a second. Oh, good. Lift that up again. I think this is the problem here. Okay. So, you know what? Let's just see. Here, I want you to, right here, right? Okay, hold that up for a second. All right, let's bring you guys around. Let's see if we can see, or give you a bird's eye view. All right, so you can see here's the manubrium. Alex is right next to the manubrium. He's holding up the second rib on that side, right? Here's the bottom of the manubrium. We're looking down into the thoracic cavity. So you see what I'm pushing on here. That's that parietal pleura that's intact. But notice over here, see it got ripped? See, that's parietal pleura. You see it's ripped a little bit there. But this side's relatively intact. So let's see. We lift up like this. I don't know how much you can see in there, but going down in there is where we're trying to pull this pleura off. So I'm kind of pushing this down while Alex is lifting up there, and we're detaching the pleura from the underside of the rib cage there. And I know it's a little maybe dark in there, but that's what we're trying to do. All right, we're almost there. Oops, now I just got to reset this thing a little bit. There we go. Just trying to get the camera up out of the way a little bit better. All right, cool. All right, so let's lift that back up a bit. Let's see if we can just get this here. Okay.
Still good.
Yeah, pop through it. One spot down there. Little. And even more here because it's completely off. Yeah. Okay, I think I got that back. That's good. Oh, pop through it again. It's right here. This last bit is always the worst. Yep, no. Okay, that's fine. I think I'm just going to zip it the rest of the way. I'm not going to be able to catch this edge, I don't think. Let's see, maybe with the, maybe. We're in pretty good shape. We went through it a little, but not a ton. I don't know if I can salvage any of this here. let's get this off. Cool. Zip this. All right, last time I think on the bone saw. Last time. So I'm turning it on. Okay. Now let me get my scissors in here. Let's cut the rest of these intercostals. And let's see where we're at. Okay. Let's see. Oh, not bad. Not bad. Right here. If we can just get this off. Just right here. Yeah, like that. There you go. Thanks. Almost, guys. We are like so close to being done. This is really nice.
Get a GoPro for this part.
Perfect. Yeah, no, it's just tough to see. Okay, so that's it. Now let me cut this off up here. So we're going to come in between. Now, right up here, all right, this is that 6th rib. This is the 7th rib. And there's a little bit of connection between the 6th and the 7th costal cartilages. So I'm just going to use the knife, and we're going to just try to split through the cartilage, and it should go. There we go. Starting to come. That's it. There. And up in there. Beautiful. Like that. And we're going to do the same thing on the other side. All right. And again, we're going to try to split this a little bit. Just get this down a little farther, something like that. Kind of come up, a little split between there, nice and easy. Beautiful. Just watch your hand there, just in case I slip. Yep. Here, you can just get your hand out of the way, just in case. Because I'm going to actually push a little bit. I typically don't push much. That's always a recipe for disaster. But sometimes you have to. You don't want to be downwind of that thing. All right, so now we're just going to cut that. All right, so last bit is we got to grab a pair of rib shears. So I'm going to go grab them.
You're not going to bust all the rest of it?
Huh?
You're not going to saw it?
Nah, it's really tough to get it. Well, now that we got it up, no, maybe I will. Can we do it?
I can lift it up.
Yeah, maybe, yeah, like that, and then we'll try. Yeah, we'll try with the bone saw. Okay, last time with the bone saw, I was going to use rib shears, but Alex is right, maybe we can do it with the saw. Right, set it down a little bit. Yeah, like that. To do this. Here, just let go for a second. So when you're lifting it, try to bend it a little bit like that. Like you're trying to like bend it down. Because as I cut, it'll start to open.
I get it.
off here. And there we go. All right, so you lay that down there. All right, let's reposition now. Now that we got that done, I think I did something flicked up on me, but you see anything on my neck or anything? Not big. No. It's a hazard of the job. It's all right. Clean up later. All right. So if anybody was taking a break, now's the time to come back. Come back. If you're not watching, and let's see if we can see. So we are going to stay on this side here. So let's get in a little bit better. Get back to my kind of point of view angle here. This will be good. Alex is just heading back over to monitor the chat. All right, so that actually went really nicely for the most part. You guys are going to be in for a treat to see a really cool picture. All right, so we kind of got that. So now, I'm standing on the left side of the body now. So I'm looking in here on the left. So now, we cut through the manubrium here. We cut through all the ribs. We cut the xiphoid process over there. We did the same thing. You can see we left all these intercostal muscles intact, right? And we cut those ones in the first intercostal space and the sixth intercostal space. So now this thing is completely off. So we can take it off. So what we're going to do is turn this over for a second so we can look at the underside. All right, so we'll kind of fit it back in place. So this is the breastplate in upside down, right? So notice, see all this shiny stuff here, right? And notice how you don't see the shiny stuff there. This is that parietal pleura that didn't want to peel off, right? Look at this here. See this edge? See the stuff I'm grabbing there? That's that parietal pleura that was really stuck on here. And that's why on this side, you see how you don't see that pleura there? That's because it's here. Because remember, if we flip this over, right, over here is over here, right? So this would be covering up there. But notice how this side, see how here is all that parietal pleura, see? Came off really nicely, see all this? And that is why you can really see like this muscle here, because you don't see that membrane, right? Because the pleura peeled off nicely over there, okay? So what are we looking at? This is the underside of the sternum. Here are the innermost intercostals that we can see here in between the ribs because we're on the inside. And then notice here, you see this muscle here, right? You see these fibers coming up this way. And you can see it a little bit underneath the pleura here. You see some fibers coming out like that. Here, 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 here. On that side, you can see there, 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 and a little bit of it there, right? That muscle, this is the top of a muscle called transversus thoracis. Transversus thoracis. So it's an internal thoracic muscle. So it's on the inside of the thoracic cavity. And it sits up against the underside of the front of your sternum and your rib cage, right? Transversus thoracis. So that muscle, the bottom of it is here. See how we kind of cut the muscle off like that? The bottom of it is under here. So it originates on the xiphoid process. It's kind of like a tree. The trunk of the tree is on the xiphoid process, and it sends out its branches out to the ribs. Like that, right? Transversus thoracis. So when that one contracts, it pulls on the ribs this way and this way. So it's going to do depression of the rib cage. So now we can see that one now. We couldn't see it before. There's another internal muscle, and those are going to be your subcostals. And once we get the lungs out, next time, right, if we can remember, Alex will try to remember, I'll try to remember, and you guys are going to post up at the beginning of next time, say, hey, can we see the subcostals, right? Just to remind us, and I will look for them. But we can't tell until we get the lungs and everything out of the body, all right? But they're behind all this stuff, a little deeper, all right? So let's get this out of the way. So we're going to move that breastplate down. All right, so what are we looking at here? So we're inside the thoracic cavity. Now, what you want to note is in this area here, we have three regions. Over here is the left pleural cavity. Left pleural cavity. Over there is the right pleural cavity. So they're on the sides. You got one region here, one region there, right? These two guys, those are the pleural cavities. And then in between that, in between my hands, so if I'm covering the lungs here, right, or the pleural cavities, in between my hands is the mediastinum or the mediastinum. That's the name for the central region in here. So pleural cavity, everything in between the pleural cavities, mediastinum or mediastinum. And again, it's the name for the central region in the thoracic cavity. Okay. In your lab handouts for the thoracic cavity, you will see the contents of the mediastinum. We're going to see a lot of them today, but you're going to note that it's everything in between the lungs, and that's going to include the heart. So we'll just list out the major things. And again, look at your lab thing for more comprehensive, but major stuff. The heart and the pericardial sac, so that whole thing together, right? Your esophagus, the lower part of your respiratory system, which will include, when we go through that, it's going to include like the lower portion of your trachea, where it bifurcates into bronchial tubes going out in the lungs, so all that lower part is in there. Plus a bunch of arteries, veins, and nerves are all going to be in the mediastinum. All right, so the biggest thing in there is going to be the heart. That's going to be the biggest thing. But after that would be all that other stuff. All right, and that's all in that central region in between the lung cavities. So let's look here. So we said that if I have the probe here, on the outside of the parietal pleura. That's that layer that was stuck against the body wall, right? So we peeled that off. Now, it's still stuck to the body wall here, right? So down over here, it's still adhered. You can see, watch what happens if I move the ribs here. See that? See as I move the ribs, look specifically like right here. See how I'm moving the ribs out, and you can see that move, right? We can see that, right, Alex? Yeah, all right. And that's because that parietal pleura is still stuck here, but we peeled it off here. Now, if I put the probe underneath, I'm in between the parietal and visceral layers there, right? And that's where we had that fluid adhesion. And then, like you can see over here, that's the actual surface of the lung, and like you can see a little bit of the lung right here, that's the visceral layer. Now, watch what happens. I'm going to get underneath of this. Get under, and I'm going to try to go that way, right? And what we're going to do here is just to give me a little bit more room. I'm just going to cut this anyway. We're going to be taking this pleura out of the way, so I'm just going to detach it down here for a second, just so I can get my hand a little space underneath there. All right, here we go. So I'm going to get under here, and I'm going to try to move that way. You see how I hit a wall, right? I try to push under the pleura, and I can't get past here. Why? Because that's where that pleural cavity ends and the mediastinum begins. And if I do the same thing on the other side, get underneath, let me see where I had all ripped apart. I don't know if we, yeah, see, I don't know. Well, maybe right there. See, I can stand up that bit right there. So there's the wall on the other side. See how I can get my finger behind that? That's that pleura. But I can't go any farther because that's where that lung cavity ends. All right, so I can get up to those spots. Again, we'll get, if I can get under here. See, I'm trying to push my fingers together there, and I can't meet because that's where the pleural cavity stops. So in between there, mediastinum. So we're going to cut that parietal pleura along right where it meets up with the mediastinum, and we're going to be able to reflect it out this way. All right, so we're going to get under here. We're just going to go right up to the edge of it. And we're going to cut all that layer that I spent so much time trying to save. Right, we're going to cut it. Oh no, here's a good picture here. So you see as we're starting to pull the parietal pleura, okay? Look right here. See this? That shouldn't be there, right? Because we shouldn't have. See how the rest of it just kind of lifted off the lung, right? So here's the lung, here's that parietal pleura, and we lift it off, and everything comes off except see how the spot is stuck. This is a fibrous adhesion. This is the result of some sort of lung damage. Okay, that should not be here. We shouldn't have any physical connection between the parietal and the visceral layers. The visceral pleura is stuck to the outside of the lung here. So it looks like you're looking at the lung, but you're really looking at film over the top of the lung, which is that visceral pleura. But we have this little fibrous connection here. See, that shouldn't be there, right? So we're going to cut that. There we go. See? You see how it's still stuck? See all that fibrous connection there? See how it's, I have to actually like tease this apart? That should not be like that. All right? We don't want to see that. No fibrous connections. You can see there's a really big one there, and that is strong, right? This is like a really thick. I'm going to pull on it a little bit. See this? Like I'm pulling pretty good on that, and it doesn't want to come. That is a fibrous connection. So if you had lung disease, like let's say you had chronic lung inflammation, you have emphysema, you know, anything, any sort of CPD, you know, any of those types of disorders causes your lungs to become inflamed. Inflammation is going to cause some of these fibrous adhesions here, okay, between these two spots. Now, one spot like this isn't going to affect you too much, but if too much of this is stuck together, it inhibits your ability to take in enough air right, to really expand your lungs. Because when we breathe in and out, the parietal and visceral layers need to slide against each other. But if we have those fibrous connections, they can't slide. You try to breathe and the lungs try to move and they can't, right? It's like a leash. You know, the lung can't really move too much because you're stuck right there. Again, if this was happening all over the place, that you would be limited in your ability to actually breathe in or out. So we're going to cut that adhesion right there. There we go. So that's off. All right, now we should be able to get in and around. And there's another adhesion over here, and I'm just going to see if I can break it. No, I can't, so I'm going to have to cut. There's another adhesion I'm going to have to cut over here. You can't really see it, it's just off camera, but it's the same exact thing that we just saw. Cut that. So what we want to try to do is reach in around the visceral layer and in between the parietal layer, and we should be able to mobilize this lung. So let's see if we can. There's a couple more attachments that I'm breaking up some little fibrous adhesions here and there to get this so that it can move better. And what you're going to see is that you've only seen a little bit of the lung. Let's see if we can. I'm going to get on the other side. And I'm going to pull the rest of this lung out a bit so you can see how big it is. All right, so we're going to reach in. We're going to try to mobilize this lung. Is that showing up? All right, see how much larger that thing was than what you thought it was, right? We were only seeing just this little part, but you got all that real big part back there, and there's still more down in there. So you see the lungs are very, very large. We're only seeing just the beginning of it there, right? So we try to mobilize the lung, and that's just a feel for those little fibrous adhesions. And my hands are going to be a little messy, so I'll try to keep them off camera as best I can. Not a lot that we can do right now until I get this area cleaned up. Right, but we try to mobilize the lung. So this one had a couple of fibrous adhesions. I'm going to try to mobilize the other side real fast. Just to see what's going on over here. This side is pretty good, right? It's got one attachment up top, one little guy. Let's see if I can. I need to cut it with the scissors. But for the most part, there we go. Yeah, just had one attachment on that side. So that side's actually pretty good. All right, so I'm going to move the camera a little bit. So instead of looking like this, we're going to look like this a little bit more, and we're going to cut this lung out of the body, and then we're going to take a look at the parts of it. All right, and I'm just going to real quick rinse my hands because they are messy. And once we get this lung out, we're going to go over the parts of the lung. Do that. Get that done. And then we're at least going to open up the pericardial sac, so I want you to see what it looks like before we cut the heart out. But we probably won't be able to get the heart out today. So when you guys come back next time, the heart will already be out. But I'm going to show you exactly up to the spot where I would cut it out. So that we'll be able to pick right up. We'll take a look at the heart. We'll do all the parts of the heart, and then we're going to do all the vasculature around here. So I know, you know, there was a bit in here where we didn't do a lot, but you saw, I'm telling you, the things that you just saw over the last 45 minutes or so, even though it doesn't amount to a lot of questions on the practical, is really important for your spatial knowledge of what is going on in here, because you're going to see once we start cutting into this more, it's going to look nothing like this, right? And notice how, see all this fatty tissue in here? This is all normal. Everybody has a fair bit of fat like around their heart and in between their lungs. Basically in the mediastinum, you see there's no fat over the top of the lungs really. It's all in here, in that mediastinum, and that's normal, right? The amount of fat you have there can vary a bit, but it's normal to have some. All right, so let's turn a little bit like this. So this is a little bit more of a bird's eye view here. Right, so I'm still standing on this side, but you're just kind of looking in like that a little bit. So we're going to take this lung, right, and this is the left-hand lung here, and we're going to move the left-hand lung over towards us like this. Oh, and you see there's another, see I missed that attachment, see, right there. So let's cut that. Let's get rid of this guy. Another fibrous adhesion there, a little bit more, see up in there. There we go. That's better. Now, see, we should be able to move this out of the way without disturbing that stuff in there. So now it's all detached. Now look at this right here. You see as I open this up, see with my fingers, I can take my fingers, I can open them up, and I can surround. See, I got something in between my two fingers there. This is all clear. This is clear. This is clear up there, but I can't go through right here. I got to go around. And what am I going around there? That is the root of the lung. This is the root of the lung here. In between my two fingers is the root of the lung. This is where all of the arteries and veins and nerves and airways that need to get from the mediastinum to the lung, they all go through the root right here. This is the only portion of your lung that is stuck to anything. Assuming we don't have any of those fibrous connections. So those aren't supposed to be there. So if that wasn't there, this would be the only part of the lung that was stuck to anything. All the other parts of the lung are free to expand and contract and move all over the place, right? Except for the root. So you also want to note that right here, I'm going to hold up, see, where is it if I can get it? Here is that parietal pleura. See how that would cover over everything? There's the parietal. Visceral is on the lung, right? But what you want to know is that the parietal layer and the visceral layer, they're actually one thing. It's all one layer. It just has a different name depending on what it's touching. The parietal layer is called parietal because it's up against the body wall. Visceral layer is called visceral because it's up against the viscera here, your lung, right? That spot right there on the root is where parietal becomes visceral, all right? So if I swing along here, see if I do this, I'm like up here and I hit the root and then I go here. This is parietal pleura up against the mediastinum there. Once we go on the root there, it becomes visceral pleura. But you see, it's all one thing, see? Visceral here, hit the root, becomes parietal. And that's going to happen all the way around. So you look right here. I'm on parietal here. I go down, I hit the root, and then I'm on visceral. So you see how I can loop around on those two things there, and that's visceral hitting the root right there and then becoming parietal up there. So as we come to the root, we fold back on ourselves. We fold back like that. We come down this way and we fold back, and that's where parietal becomes visceral all the way around here. So it's all one continuous layer, and it reflects on the root of the lungs, if that makes sense. All right? So we're going to cut through the pleura right there. I'm going to cut through the pleura, and then we're going to have some of the vasculature in there. So we're going to see, you know, the veins, the arteries, and the airways that connect to the lungs, and we're going to cut those things. All right, so let's come up in here, and I'm going to shift up a little so that when I'm doing this, I'm not messing up the autofocus so much. I think. Is it autofocusing on me, or it's okay? Okay. So you see that there? See, I'm inside of the root. So this is right in the junction between parietal and visceral. Okay, so we're going to cut that. I'm cutting the pleura there. Get all that out. We're going to open up this area. Again, I'm just kind of going through fascia. And we're going to start highlighting some vessels here. All right, so right here, this guy that I'm going around there, that is your part of your pulmonary artery, which is blood supply out to the lungs. So I'm just going to clean this a little bit more. Again, I'm just creating some space here. So hopefully we can see these things. And then once we can see them well, we can cut them better. So yeah, you're starting to see some vessels here. See this guy? Here, up there. So that's the artery. Arteries here. This is a pulmonary vein here. And there's another one below it that we're going to open up here. See? Okay, this is all big pulmonary vein here. There's the artery. So now that we got these cleaned a little bit, I'm going to cut them. Now, this might become messy because there's blood in there still, right? Now, the blood might be coagulated. It might not be. And if it's not, then it's going to make this kind of messy, and there's not a heck of a lot we can do about it. But let me just, oh, there we go. And just pop the artery just a little there on accident. Now it's coming out. So let's see if we can just cut this clean. There we go. So I don't know if you guys can see here. See that? Is that showing up a little bit, Alex?
It is.
Right there. That's the artery that I just cut. Now I'm inside the artery there. Right, and now it's a bit messy down here, so it's kind of hard to see the other side of it, but I think I got it there. Now let's do this vein down here, and now you guys are not going to be able to follow along too well because it's going to be pretty messy, but it's all right. Okay, so that was the vein. And I don't know if is that showing up there, Alex?
It is, yeah.
See that? So here's the artery up here. There's one of the veins down there. And the main thing that we're left with, and you guys are not going to be able to see it because there's just too much fluid down in here, but you see this little crown coming up right here? Can we see that just a little? Right? That I'm going around? That's the airway. That's a bronchial tube there. So I'm just going to get my fingers around this so I can feel. You're not going to be able to see, but we're going to feel exactly where that is so we can cut it nicely. Come down and hit that. You see those air bubbles coming out. See that? Right? As soon as we cut that airway, right? I'm pushing on the lung a little bit, and that just squeezed a little air out of the lungs, right? Coming up this way. So it's kind of cool to be able to see that. I see Alex has a smile on his face because he has not seen this before. So, right?
A lot of this actually.
Yeah. So doesn't always, that's why I try to do this in front of you guys. Try to give you something that you wouldn't necessarily have seen. I mean, Alex, how many times have you took the class, right? And how many times have you assisted so far?
4 times.
4 times he's assisted. This is the first time he's seeing this. So it's good. You know, it's like everybody get a little extra that you don't normally see, because a lot of times I just do this, you know, when nobody's in here, but there's a lot of valuable things to see here. So let me just get behind. Now I just have to just get in here and cut. This is not really, I can't really show you anything because it's too much fluid in there. So I'm going to get in, I'm going to snip this stuff out of here. All right, almost done. Tiny bit more. Come on now. Sorry guys, I'm just trying to, it's like blind. I can't really see what I'm doing because there's too much of a mess and it's really stuck in here. There's a bunch of fibrous adhesions. Don't want to come. There we go. Oh yeah, really stuck down here.
You may get the check.
No, not yet. We're good. Okay, so let's lift this guy out of here. You know what you can do is check in the drawers, in the cabinet below you. Is there a box that has rags in it? A box of white rags, like whitish towels?
No, it's just clipboards in here.
Okay. Where did I put it? Let's try over here. So not there. Oh, it's right there. Up there. Is that box? Yeah, just pull that down. Just grab out like 2 rags. Perfect. Let me just grab them from you. Awesome. Thanks. All right, we just wanted to get a clean rag that I could put this down on top of. So hold on a second. Get this here. Let's fix this up. Let's come out a little bit. And let me just wipe off my hands a little. Okay, let's come out a little bit. Get up there. There we go. So, just we'll zoom back in, but I just want you to have this kind of bird's eye view for a second. Cool. All right, so the lung's attached, so let's lift this guy up and out of here so you can see. All right, there's the whole lung. Is that on there? All right, you can see it. And we're going to move it down there, but I'm just going to set down one of these rags. Put it on top of for now. Switch down like that. All right, so now we can see how much bigger that lung is there. Now there's a little perspective going on here, but so it's looking a bit bigger than it is, but still, if we I'm going to get more, give you that point of view so you can kind of see. So it looks like that. And let's move up a little bit so you can see the space that it came from. See, like that. Now what's happened is as soon as we pulled the lung out, right, I'm pushing against the heart. This is the heart that I'm moving right here. The heart is like, I'm going to trace it. It's like this right here. The heart is settled over this way. So really it would have been more like that. See how that gives us a little bit more room, right? So we're looking into where the lungs were. You can see there's some fluid down there and everything. Here you can see those vessels that we cut. See those openings there, right? This thing, as I move this over, see this right here that I'm pushing against? That's the diaphragm. That's what separates the thoracic cavity from the abdominal cavity, so I can push against the diaphragm. And actually, what's behind the diaphragm here, what am I pushing against? That's the stomach, mostly. All right. So this is that left pleural cavity, right? And here's that parietal pleura that we had seen, right? That was what was covering it up, and now there's nothing in there anymore, right? So we can see that. So let's slide down. So we got a nice picture there. Let's slide down here so we can see this lung better, like this. All right. And this is a really nice lung, really, really nice. So right now I'm holding the lung the way it was in the body. All right. So this is exactly the same orientation you just saw in that pleural cavity. So this is superior, that's inferior. You're looking at, sorry, I got lots of stuff in my fingers here. You're looking at the lateral side, and if we flip this over, this is all the medial side, right? This is how it sits. But I'm just going to turn it like this, just to orient it with the way that we're looking right now. Should be a little bit easier. So we kind of got that. Let me just move down a little. Something like this. Yeah, come on now. Sorry, the camera's not cooperating. There we go. Something like that. Right, now I can bring this. Yeah, there we go. Perfect. So now I'm kind of holding it in line with me. So this again, here's the top of the lung. That's the bottom, right? It would sit in the body like this. So this is the anterior side. That's the posterior side, right? So it would sit like this. So I'm kind of laying it down. So we're looking at the lateral side of the lung. All right. Now, one thing you want to notice is that we have this large split. See that? From here and here. We got this big division between here. This is separating the main two lobes of the lung. So this here is going to be your superior lobe. You see it goes up a little farther, like up towards the top, superior lobe. And this over here is your inferior lobe. And what separates those two things is a fissure. And this is going to be your oblique fissure. Okay, let me use the probe instead of my hands. Okay, so I'm going to put the probes in the oblique fissure right now, separating superior lobe from inferior lobe. All right. Right away, since we're only seeing one fissure here in two parts, we know we're looking at a left-hand lung. Left-hand lung only has two lobes. When we take out the right one, which will be out next time, and I will show it to you just so we see the difference, the right lung has three lobes. And the difference being that it has an additional fissure. All right. So in addition to the oblique fissure, and look I'm holding this in line. This is top, bottom. This is the anterior, that's the posterior side. And you see it is going oblique, right? There's going to be another fissure on the other lung, which is going to go like this here. It's going to be horizontal. All right. And that is going to create a division between the superior lobe and a middle lobe. Right? So if we had the probe like that, see how we're kind of dividing the lung into 3 spots now? If it looked like this, you would know you're looking at a right-hand lung. If you don't see that split there, and we only see here, then you're looking at a left-hand lung. Left-hand lung's got 2 lobes, superior, inferior. Right-hand lung's got 3 lobes, superior, inferior, middle. And that's how you're going to tell the difference. You're going to look for 2 or 3 parts. All right, you'll know which one you're looking at. Outside of that, the lungs are going to be the same. It's just that that right-hand lung's got an additional fissure and an additional lobe. All right. Next thing we want to determine are the surfaces. Okay, and for this, I'm going to go back and we're going to hold the lung up in place a little bit. Again, so let's kind of do this. Hopefully we're far enough away. So you kind of see how the lung, look at how much bigger that looks, right? And it's just because, again, the heart has kind of moved over, so it kind of took up a lot of the space there. But if we plunked the lung back in like that, right? The surfaces of the lung are named for what they come in contact with. So you see how this side of the lung, if we put it back in, would be up against here, up against the ribs, costal surface, right? So the whole lateral aspect of the lungs, all this whole side here, all that would be up against the ribs, costal surface. This side of the lung, let's move up a little bit, the bottom of the lung here, the bottom of the lung would be up against that, which we said was the diaphragm, right? So that part of the lung, see, it would go down, and this part would sit against the diaphragm. That would be the diaphragmatic surface, and I'll just show you, see how that's this part here, right? And the diaphragm is dome-shaped. You see how it would match to the bottom of this because this is cup-shaped, right? So that part, this right here, would sit down and go up against that there. So their diaphragmatic surface, all right? And then we said that all of this stuff, right, everything in the middle, all of this is the mediastinum, right? So if the lungs are going to go back in and I'm going to put the lungs in like that, then this side, all of this would be up against there. So this would all be mediastinal surface. That would be the medial side of the lung. And then look, what's on the medial side? There's those openings. That's where the root was. See? Right here is the root of the lung. And then that matches up to, see, we can see those same openings down in there. So there's where the root was there. All right. So you have those surfaces. Costal, diaphragmatic, mediastinal. Now, there's one additional surface on both of the lungs that we'll talk about now. And what you want to see is if I lift this up here, I'm lifting the heart out of the way, right? So this is all mediastinum here. But look down there. You see this big tube that I'm outlining there. Can we see that, Alex? We can see it, right? I'm kind of outlining it right here. There's a really big tube. I'm kind of moving it right there. That's your aorta. All right, and we're going to clean that up a little bit later on, but yeah, there we go. I'll try to get my hands out of the way. That's the aorta there. So we got mediastinum up here, and then there's the root of the lung, right, where those openings are. And then if we go posterior back there, we're on the aorta. So on this side, behind the mediastinum, posterior to it is the aorta, which means the lung's going to have an aortic surface. On the other side, so if we were going in from the right-hand side instead, we'd be up against the mediastinum going in this way, but behind the mediastinum, instead of the aorta, you'd be up against the bodies of the thoracic vertebrae. So on the right side, that same spot would be called the vertebral surface. So that's the only thing that changes. All the surfaces are the same, except on the left-hand side, aortic surface. Right-hand side, same spot, vertebral surface. And I'll show that on the lungs right now. So let's move down here. All right, you can probably turn that brightness back down a little bit. All right, so we kind of, there we go, get that in there. Okay, sorry, I know the camera's moving around. Okay, so again, we're going to turn this over, right? So we're looking at, this is all the medial side of the lung, all right? Here's the root. From the root anteriorly, so basically what my hand is covering right here, that's mediastinal surface. You see we're left with this part right here. And look at that. You see how there's a groove? Right? See my fingers going through a groove here? That's where it would have been up against the aorta. So this would be aortic surface. So that's aortic. All the rest of this is mediastinal. So you see on the medial side we got 2 bits. Mediastinal surface, aortic surface. If we were looking at a right-hand lung instead, it would look like this, and we'd see a groove here, but that groove would be up against the vertebrae instead. So this part would be vertebral surface if we were looking at a right-hand lung, and the rest of this over here would be mediastinal surface. Okay? So be aware of the surfaces of the lungs, the lobes of the lungs, the fissures. The only other feature we need until we get into the openings is if we turn the lung back, so we're looking at it, kind of stand it up like this, right? I'm going to move it down a little bit, is the very top of the superior lobe, right up here. The most superior portion of the lung is going to be the apex of the lung. So the very top of the superior lobe, apex of the lung. Okay? Now, let's flip this over, and let's look at openings here. We're going to zoom in a little. Like that. So we're kind of zoomed in on the root of the lung now. So we're right in here. We're in on the root. And let's see. Now I haven't, this is still, see, it's a little bit bloody. There's still some stuff in here. And actually, let's pop that guy out of there. There's a little bit of coagulated blood on the inside. Get this out of here if we can. Come on now. It's going to come out nicely, or no, it's going to make me work for it. Let's get that out of there. Of it, I think we can make do with here. So I'm going to rinse these lungs when we're done. I just didn't want to take the time to do it right now, but they'll be all this stuff will be out of here. It'll be nice and clean for next time. But we can see this large opening here. We can see this opening here, right? We can see this guy here, and that guy down there, and it's still got a little bit of blood bit there, right? So we can see all those openings. Now, first things first is we look for the thickest opening we can find, and that is going to be this guy right here. That is going to let you know that you're looking at an airway. All right, so this is a bronchial opening here. Notice that the walls are very, very thick, and watch what happens when I push against this. See how it moves as like one piece. See how I'm moving it around, but it's not collapsing really. It's all kind of moving as one piece. That's going to let you know you're looking at a bronchial opening. Why? Because there is cartilage in the walls of this, which is why it's so thick, and it maintains the opening there. Right? So your airways are always open because of the cartilage, all the way down until we get towards the alveolar sacs deep in the lungs. Then there's no more cartilage, but you get down pretty far inside the lung and the cartilage is still maintained. So that'd be an airway. Now let's just see. Let's see if this will do this for us. Yeah, look at this. See that? Looks like soap bubbles in there. All right, let's see if we get a little bit more to come out. There we go. There you go. See that? Right there. Look at all that. That is surfactant that you're seeing. And that also is going to let you know that you're looking in an air opening. So there literally is, surfactant is one of the components of soap. Okay? Surfactant is what causes all the fat and everything to break up. So you ever see like those old like Dawn commercials where they have like a bunch of grease and they put a drop of soap in there and the grease all scatters, right? That's surfactants that are doing that. And you have surfactants inside of your alveolar sacs down deep in your lungs, and that's what prevents the alveolar sacs from collapsing on themselves. Because remember, when we had two layers next to each other in the lungs, we said the parietal and visceral layer stuck together because of surface tension, right? Well, the same thing would happen down in the alveolar sacs. It's basically just a sac. It's a bubble of fascia, and that bubble would collapse. The surfactant makes it so that the surface tension is much, much lower, and those edges don't stick to each other, right? And that's how we breathe. If we didn't have that surfactant in there, you would not be able to breathe. Right? Nothing would happen down in those alveolar sacs. So we can see it, but once this dries out, you won't see this anymore. But when we first take out the lung, you can see it a little bit. So that was a nice picture of that surfactant down inside there. And again, that's letting you know that that is one of the bronchial openings. All right? Now, next thing you're going to look for is this guy over here. See this real big guy here. This is going to be a pulmonary artery. And what we're going to see, and hopefully, I don't know how well I'm going to be able to do this. All right, like that. So you see how this one, I can collapse it, right? I can take this side and I can push it down. I can collapse it, but I let it go. You see how it springs back into place? See that? It's like pretty springy, right? Push that down. And once, especially like right there, right? That's a good picture. Very springy. That's going to let you know you're looking at an artery. So the arterial walls have a fair amount of muscle in there, and that muscle is going to give you some elasticity and some resilience to the edges of this vessel. So it doesn't like to be collapsed. You can squish this all down and it'll tend to open back up again. So that would be a pulmonary artery here. The last two, this guy and this guy, are going to be pulmonary veins. Now let's see if the veins will do what they're supposed to do. We push that down. See? Kind of stays shut. It's starting to come back out, but it doesn't have nearly, it's not like this one. Push that down. See how that pops right back up. See that resiliency versus this guy, we can really like get in here. And even up top, look at that, right? See how we kind of push that down? It just stays down. All right, so the veins are much more collapsible because they have less muscle. So they're thinner vesseled walls. They're pretty flimsy. Right? We can kind of see that, and when we collapse them, they tend to stay collapsed. See? Trying to come back up just a touch, but not really. If we really want to see it, I got to move it back into place. That would be a pulmonary vein, and this guy down here is going to be the same. You can see the same type of thing. See, right now you can't even tell there's an opening there unless I come in here and I actually open that guy up a bit. Right? Another pulmonary vein. We do that and it stays closed. So note that if I ask you openings, I'm going to do it just like this. I will orient you. This is the top. This is the bottom. This is anterior. This is posterior. And I will show you where the things are. But really what you're going to look for is, you know, if I said identify this opening here, and if I push against the opening, you can see how it moves. You go, well, that's not collapsing at all, right? And you can see the walls are thick. Air opening. That's a bronchial opening. You could say air opening or bronchial opening is fine, right? If I showed you, if I said identify this opening here, and I said, let me show you the walls, and I did that, and you saw it spring back open like that, it's an artery. If I said identify this guy here, and I kind of opened it up like that, I said identify that opening, and look at what happens when I push down on it, and it just stays down, vein. So it shouldn't be too hard for you to pick out the difference because I will do that on the practical. I'll say identify this opening and I'll show you how that opening moves. Okay, so I think we're going to call it there. We went pretty far. So at least we got done with the lungs. We saw all the compartments and everything. And then next time, like I said, I was going to start the heart, but I will just recreate it for you next time. So what we're going to do is, this is the pericardial sac that I'm kind of moving around here, right? So the heart's in there. So we're going to cut open the pericardial sac next time, and we're going to move away the parietal pericardium. We're going to see the heart. It'll be covered with visceral pericardium, and I'm going to have cut some of the openings in and out of the heart so we can actually take it out. But I'm going to clean it. It'll be a mess if we take it out now. It's going to be pretty bloody in there, but I will clean this whole area. Everything will be nice and clean. I'll have it all sectioned and ready to go. So next time we will start with the heart and the parts of the heart. So we're going to do chambers, openings, all that kind of stuff. Then we will do following the arteries and veins out away from the heart, up and around in the thoracic cavity. We're going to do that as well. Okay, so that'll be on Wednesday. So if you guys need anything, I will have a help session. I will have one later on today. I might still be down at the lab dissecting, but I will have it and I'll just do it here. Okay, so I'll just leave you guys on, and if you need something, I can pop over to the computer. All right, so have a nice day, and I will see you guys either later today or Wednesday.